after prosthetic. تفضل.
Who is the one who did the brushing of bladder stone and transvator resection just half an hour ago?
As well. So, good afternoon. You're welcome in Mansoura. I'll try to keep inside as much as I can. I know it's a bit late. You are asleep. So today we are going to talk about PBH new technology. And in my talk, I'm trying to cover what is the gold standard treatment for PBH. Do we need a new technology? What are the new technologies available? And does it work in a developing country like ours? So what is the gold standard? So gold standard is defined as the monetary standard. Okay. The monetary standard under which the basic unit of currency is equal in value and exchangeable for a specific amount of gold. And in surgical terminology, it is a test of value of a procedure that is considered superior under different circumstances and widely available and accessible to the majority of the population being served. We're looking for PBH. For years, the gold standard is transurethral resection of the prostate. It's almost always referred as being a gold standard. On which basis is it based on the randomized controlled trial? Have we ever compared TURP to a previous gold standard? No. Only test of time. For 50 years, TURP is the test of time, and it is the gold standard everywhere in the world. However, currently, we do have a challenge for TURP, for transurethral resection of the prostate. So if we ask ourselves, does TURP fit all the time? I don't think so. Because in a patient with bleeding tendons, oral anticoagulation independently impacts the TURP outcome, and it's significantly associated with longer hospital stay, higher rate of bleeding, blood transfusion, late hematuria, and thromboembolic events. What else? In naturally anticoagulated patients. Here in Egypt, we have a lot of naturally anticoagulated patients. Patients with chronic liver disease. In our locality, we have high prevalence of hepatitis C virus, high morbidity and mortality from chronic liver disease, cirrhosis, and hepatocellular carcinoma, ending up by different grades of liver cell failure and uncorrectable coagulopathy. So you cannot treat this patient with TURP, with regular TURP. When we look for the outcome of TURP as regards the prostate size, with this prospective multi-center evaluation of almost 11,000 patients from Germany, when they start to treat this patient with regular transurethral resection of the prostate, if they resect more than 60 grams, there is significant increase in the perioperative morbidity and mortality. Blood transfusion rate reaches almost 10%, and surgical revision is almost 10%. So it's not the best for large size prostate. Randomized controlled trials of transvesical prostatectomy, open prostatectomy against TURP for large size prostate showed that more tissue was removed with open prostatectomy and better functional outcomes as well with open prostatectomy at 12 months in terms of symptom score and flow rate. This is our study showing the perioperative morbidity of almost 43% for patients treated with open prostatectomy and up to 1% mortality after open prostatectomy. And when we looked with this nationwide study from Austria and long-term morbidity analysis of almost 23,000 cases of TURP and open prostatectomy, the overall incidence of secondary procedure, in other words, really do for TURP or urostomy or bladder neck incision is almost 15% after TURP and 10% after open prostatectomy. In other words, TURP is fine procedure. As long as we remain within our limits, we treated an index patient with an average size prostate, no coagulopathy. But what about the global pictures throughout the world? Many surgeons referred to and still insisted that other technologies, lasers, all other technologies are superfluous for surgical management of BPH in a developing country. So again, the question, do we need a new technology? Yes. The patient coming to us as a surgeon to treat is a change. Long-term BPH medical treatment ended up by larger process coming for surgery, so more morbidity, and more older patients are coming for surgery. So they are more comorbid, more anticoagulated, more pacemakers, and frequently coming with indwelling catheters for urinary retention. So the new technology is coming. Why? Meaning less invasive, low morbidity, shorter hospital stay or day surgery, shorter caster time or no caster at all, fit for bleeding tendency. There is no size limitation, and that is cost effective. So what are the new technologies? The new technology come in energy source which work in a physiological sign as arrogant to avoid working with glycine and the risk of TUR syndrome. A new technique associated with less bleeding and more tissue removal, so we can treat whatever size prostate. So this image is very useful for understanding the physics of lasers that we are using. So this is the electromagnetic spectrum, and here what's called the visible light from 400 to 700, and this is the ultraviolet spectrum, and this is the infrared spectrum. We have our lasers lying with their wavelengths throughout this spectrum. And how does it work with us? So we have two famous lasers, which is the green light laser, the KTP laser. Its wavelength is 572 nanometer, and with this wavelength, it's absorbed mostly by oxyhemoglobin. And the other kind of laser, which is holmium laser, it lies here in the infrared spectrum, and with this characteristic wavelength, it's absorbed mostly in water, as we have described during our work today. What is the other energy source? It's the plasma. It's an electrosurgical technology, depends on conversion of the standard electricity via a special generator to cut and coagulate tissue. This orange color is the plasma. It's used to be generated by the bipolar electrosurgical units. And what are the techniques? We are going to tackle the prostate adenoma about whatever kind of technique. We can use vaporization of the prostate adenoma. We can resect as we did today. We can vaporesect, valve-inoculate, and we can do complete inoculation to peel the adenoma from the surgical capsule completely. So, the godfather of inoculation is what's called holmium laser inoculation of the prostate, or HOLIP. I will go in 30 seconds throughout this video, showing the principle of holmium laser inoculation of the prostate. We are using the holmium laser energy to cut through the prostate tissue and dissect the adenoma, peeling it off the surgical capsule. So we are using the same piece of equipment that you have seen. We cut through the prostate tissue to identify the surgical capsule, and then we use a blunt movement to identify the natural plane between the surgical capsule and the adenoma. This is exactly what you used to do while doing an open prostatectomy. Instead of using your finger to dissect, to go between the adenoma and surgical capsule, you use the tip of the scoop, and you are assisted by being under vision and then using the laser to cut and coagulate simultaneously. You are going to peel off the adenoma completely from the surgical capsule, pushing it toward the bladder, and then you will be in need to retrieve the prostate tissue using what's called tissue morcellator. So again, finally we push the adenoma to the bladder, and we will suck the tissue out using what's called tissue morcellator. Let us look about the results or the outcome of HOLIP as regards the efficacy, safety, and durability. So the data have shown that there is equivalent symptom score reduction to both open prostatectomy and transurethral resection of the prostate following HOLIP. And furthermore, the hemodynamic relief of obstruction with HOLIP is superior, or at least equivalent to TUR and open prostatectomy. And based on the resection speed, HOLIP is faster than TUR and similar to open prostatectomy. And percent reduction of PSA and prostate volume following HOLIP have been reported to be as high as almost 80 and 86% respectively. And this is what we can obtain after 4 months by transrectal ultrasound. This is a very nice prostatic fossa following HOLIP, allowing free flow of urine. And the efficacy and visibility of HOLIP has been also proven for recurrent or regrowing prostatic obstructing adenoma after previous transurethral prostate surgery with similar outcome. It's safe, being done in different sizes of prostate, so it is a size-independent procedure. It's safe in the elderly patient above the age of 80. It's safe in patients with ongoing anticoagulation or antiplatelet therapy. And blood transfusion rate has been reported to be less than 1% following polyp. We are using it physiological saline, so there is no risk of QR syndrome. As regards the durability or the leak-free operation, the anti-incontinence surgery following polyp is less than 1%. And in a study of almost 1,200 patients with a median follow-up of 7 years, following polyp, the freedom from hemorrhage operation was 97 at 5 years and 95 at 10 years. So, what are the other techniques? Tissue vaporization. Again, the best laser for tissue vaporization, or the actual laser that we do have here, and we are using it for prostate vaporization, is the green light laser. So, we have this 57-year-old male. He had an inguinal visceral catheter for acute urinary retention with failed trial avoiding trial 4 times on medical treatment. He had a liver cirrhosis with prothrombin concentration 44%, platelet count of 65,000, and his prostate 65 grams. If you do have only transfusion section of the prostate, the procedure will be quite morbid for such patient. And we often end up by asking him to have the catheter in the wedding. However, we can treat him with a green light laser, photoselective vaporization of the prostate. The main criteria of such type of laser that it is absorbed by the oxyhemoglobin, so it has a high affinity to the tissue which is rich in blood, which is the prostate. So by application of this light laser energy, it will end up by conversion of the prostate tissue into bubbles, vaporizing the prostate tissue. Regularly, when we start whatever kind of transurethral prostatectomy, we start by creation of a working channel. Similarly here, while we are using the green light laser, we are aiming the laser to convert the prostate tissue into bubbles, creating a channel starting from the bladder neck to just in front of the peritoneum. The procedure starts at the bladder neck, extending distally, and we start to vaporize the prostate circumferentially. What is? We have the resection. We can use what's called the plasma. And what's plasma? This is a new form of energy that's generated during bipolar resection of the prostate. It's fast, effective, induce cutting and coagulation at the same time. While the main advantage of this kind of technology is that it uses the physiological saline, which nullify the risk of QR syndrome. So this is a new technology that we do have. But does it work in a developing country? Does our resources accept this new expensive technology? Let's take a look. This is the question of our piece of research that we have already published in the World Journal of Urology. So we looked at our experience at that time, which was 400 Holly procedure. Our study was entitled Holmium Laser Enucleation of the Prostate for Treatment of Large Size Benign Prostatic Hyperplasia. Is it a realistic urologic alternative in a developing country? So, we did what's called matched pair analysis. We tried to compare, according to the resected prostate weight, between polyp and open prostatectomy. We have 92 polyp procedure compared to 91 open prostatectomy procedure based on the mean resected prostate weight. And when we look to the hospital stay and catheter time, we have found that the polyp has significantly shorter catheter time and hospital stay in comparison to open prostatectomy. Furthermore, when we look to the efficacy parameters or the functional urinary outcome parameters, as regards symptom score, quality of life, and max and peak flow rate and residual urine, both of them significantly improve after polyp and open prostatectomy in a similar way. So both of them are equally effective. Again, when we look to the post-operative PSA reduction, we used to use PSA reduction after surgery as a surrogate marker for the prostate volume reduction. So, here we have almost 80% reduction in the post-operative PSA, which means, in other words, 80% reduction of the prostate volume after surgery. It is similar, it's almost similar between open prostatectomy and Holly. When we look for the reoperation rate, we do need one case of incision of the bladder neck contraction after open prostatectomy, no need for redo for either growing or residual adenoma, and one case for issue restriction was treated after each procedure. When we look to the peri-procedure blood transfusion, significantly lower after polyp, it's almost 2% in comparison to 25% after open prostatectomy. And when we look at the last follow-up, stress urine leakage, which was in low grade, it's almost the same, 2 0.5% after polyp and 1.5% after open prostatectomy. However, this is our main target of such a study. When we look at the cost, we started to study the cost as per item, including the laser to capital machine price, morse-related machine price, reusables as a laser fiber and morse-related plates, perioperative irrigation, blood transfusion, the need of ICU admission, hospital stay, and readmission inpatient stay. All these are not applicable in open prostatectomy as this equipment, however, we counted for their price. As regards the perioperative irrigation, we are able to record after whole, but unfortunately with open prostatectomy we are not recording, so it's missing in open prostatectomy. And as regards the main difference comes from the hospital stay. We have significantly more cost on the hospital caused by longer hospital stay induced by after open prostatectomy. So when we come to count it in money, after 2 years of purchasing a laser machine, all the procedure cost the hospital almost 4,000 Egyptian pounds in comparison to 4,300 Egyptian pounds after open prostatectomy without statistical significant difference between those groups. So we came to a conclusion that in high volume hospital, whole procedure seems to be equally safe, effective as open prostatectomy with the advantage of minimally invasive procedures. 2 years after adopting such technique, whole equally cost the hospital as open prostatectomy, and significant hospital cost savings are anticipated in subsequent cases. My take-home message for you before leaving that the gold standard is a moving target. It's not fixed. So it's better to be defined and the treatment modality available at your hand while your outcome is optimized using it. We do not have to rush following the media pressure or the industry market, but we have to look for our needs and our resources. And thank you very much.
Thank you, Dr. Ahmed, for this very nice lecture. Any questions from the floor? More questions?
Any comments for the previous two cases in the OR?
حضرتك لما عملت سيكشن أحدت الأورية بتاع التراكم كان فيري سين وأنت بتعمل السيكشن بتاع البروستات كانت الأورية بتاع التراكم فيري سين، معناها إن حضرتك شفت كل البروستات تشرب تقريبا. فكومنت بتاعك إيه في الحتة دي؟
So I did resection in the transverse capsular fiber that the bladder neck. So this is my intention. As I said before, I start to resect shallow sections at the bladder neck, getting deeper while I'm resecting at the mid fossa and shallow again while I'm resecting at the apex. Because if you look to the shape of the prostate, it looks like this separate shape. So you are resecting shallow. And I'm keeping the bladder neck fibers high till the end of the procedure. At the end of the procedure, I have to inspect the triangle and compare it little to the level of the bladder neck. And eventually, at the end of my procedure, I realized that the triangle and the bladder neck fibers were almost at the same level. So I don't need to make a deeper incision at this level. And I think this is the only way to protect yourself against going underneath the triangle or using what's called retrotriangular force passage.
طب ولما شفت التيبيكال بارتس اللي حوالين الفيرو حصل elevation of the الفيرو شويه، يعني انت حريص على ان انت تشيل كل البروستاتيك تيشو في التيبيكال بارتس حوالين الفيرو.
Just an anatomical landmark to delineate your limits of resection. However, it doesn't mean that the sphincter is there. The sphincter is a bit beyond the level of the peritoneum. It's a bit distant to the level of the peritoneum. So you have visually to inspect and look for any residual tissue. You have a landmark, which is the capsule, and the capsule at the apex is white, opalescent with running blood vessels. So you have to look for it. And the prostate tissue is fluffy. line. So you have to identify your endpoints. And we were resecting, we are able to see the prostatic calculi or calcification, which is a very nice landmark to differentiate between the adenoma and the surgical capsule. So I'm resecting tip and reaching the surgical capsule regardless of the lip of the verumentana. And our endpoint is iterable cavity with a tongue-like projection of the verumentana. So I'm looking to have the veil projected in this way.
I'm very interested in this presentation. Thanks.
Any more questions? So I hope that you enjoyed your second day in the course and we think we will do tomorrow, inshallah. Tomorrow will be the day of laparoscopy. Okay? See you. Thank you.
Just one comment. Thank you so much for this inviting presentation. Also the surgery and investigation. Of course, I'm from Zambia. Even our resources, this information may reach us 20 years from now. So this has it's been a lecture that has thrown us into the future. And we are so privileged that we could see it now. I rotated in a department of urology in China, in Wuhan Hospital. This information is what actually they are looking for. They were trying for laser and just what we presented. So Mansura, to me, presents knowledge that even a country that is pushing the size of China, they look into this information. So what you are doing here, I think for other participants, it's something that is indeed state of the art. It's elevated us to a level that we know that Africa has something to, incredible to offer. So I'm so grateful given on behalf of the other participants. This is extremely very good.
It's an honor for us to have you here with all of the friends with us, and you're always welcome. And I hope that you have this technology not after 20 years, maybe next year.
But we did the combination that in the live transmission, we transmitted the orthodox treatment, which is the gold standard transurethral resection. It was done in the live morning. And in the afternoon, we give something for the future. So we did the combination